Good morning, those of you that are joining us in the far west in Vancouver, BC, and everyone else, good afternoon. My name is Karen Taylor-Hughes. I'm a member of the Pan-Canadian Change Management Network, and we are hosting this Change Management webinar. Thank you for joining us for The Only Constant is Change. Today we'll hear from family practice leaders as they share how leading change is just business as usual in their practices. Notice of recording. These sessions will be recorded and may be posted on Infoway's website, used for future internal or external education sessions. Please use the Q&A feature if you wish to ask questions. The moderator will pose your question on your behalf. Your name will not be used. At this point, we will be using them. The Q&As will sit on the side, and at the end of the session, we will have a time for question and answer. Disclaimer, I'm going to have you read for a few seconds so that you know that these are the views of our speakers and that we in no respect, they in no way reflect Infoway's thoughts and or intentions in regards to investment criteria, etc. And that we do not implicitly or explicitly endorse any particular technology, solution, or methodology. Today our presenters are Mark Desjardins, Executive Director at the Assiniboine Medical Clinic in Winnipeg, Manitoba. Joining him will be Dr. Brian Rumbold, Family Practitioner at Assiniboine Clinic, and then Mirella Chiodo, Quality and Informatics Supervisor, Department of Family Medicine, University of Alberta. Today's presentation objectives. This webinar will provide insights into the journey underway at Assiniboine Clinic to implement a preventative focus to chronic disease management, how leveraging the National Change Management Framework elements, stakeholder engagement, and communications have helped bring all members of their practice on board, the development of a quality and informatics team to roll out large-scale changes across multiple clinics, leveraging communications, training, and education, monitoring and evaluation in a family practice environment. Our presentation outline, we'll hear a little bit briefly from myself around Canada Health Infoway and the work that we do at the Pan-Canadian Change Management Network. And also, we'll talk about the presentation will come up, and then we'll have a question and answer period, and then we'll be able to show you where available resources are. Again, to ask questions during the webinar, all attendees' phones have been muted, but you can definitely put your questions as they come up in the Q&A panel, and we will address them once the presentations are complete. Canada Health Infoway is a not-for-profit corporation created in 2001. We have received $2.1 billion in federal funding. We are accountable to 14 federal, provincial, territorial governments. Our mission is to foster and accelerate the development and adoption of electronic health information systems with compatible standards and communication technologies on a pan-Canadian basis with tangible benefits to Canadians. Infoway will build on existing initiatives and pursue collaborative relationships in pursuit of its mission. The Pan-Canadian Change Management Network is a collaborative that forms to successfully communicate, educate, and promote the value of using change management methodologies, approaches, and tools at every stage of e-health solution implementation and adoption. The vision of the Pan-Canadian Change Management Network is to be recognized as a leading national network for change management approaches and resources that support successful adoption of e-health solutions. As mentioned, the National Change Management Framework was actually created by the network, and it's an information and perspectives gathered through the network resulted in the creation of our framework based on 6 core elements: governance and leadership, stakeholder engagement, workflow analysis and integration, communications, training and education, monitoring and evaluation. We believe that these are the 6 core elements that support best practices for change. And today we'll hear from our presenters how they've leveraged some of these elements to support their change. I'm now going to pass over to our first presenter, which is Mark Desjardins, and to Dr. Brian Rumbold, to tell us about their experiences at Assiniboine Clinic. Welcome, Mark and Dr. Rumbold.
Thank you. So we are going to talk a little bit about our chronic disease prevention and what we do within our clinic and how we've implemented that change. So first, a little bit about ourselves. We are the Assiniboine Medical Clinic. We're a family practice-focused clinic that's fairly large, 17 family physicians, 3 surgeons, 3 urologists, and internists. We have a fairly large complement of staff. We have 1 staff member per physician, as well as some other support staff like billing clerks, transcriptionists, and et cetera. We provide care for approximately 30,000 patients a year, and including all of our additional services like EKG and X-ray, we actually have about 150,000 patient contacts a year. So we're a busy place. To keep all that organized, what we typically do is we run with what's called our management committee. This consists of 3 family physicians who are elected to the group, and every year one steps away, a new one comes in, and they constantly rotate, so we have fresh blood coming on every year. They have a weekly scheduled meeting every Thursday at 3 p.m. to discuss any matters relating to the clinic. This includes things that are related to change management, like our chronic disease, or this could be relating to something else, patient complaints, things that we feel need to be addressed. Having that dedicated time slot each week has really helped us keep on top of changes as well as keep things steadily progressing forward. We try not to have any useless meetings. There's always something to discuss, and if there isn't, then we cancel the meeting and go about our business as normal. We also have a shareholders meeting once a month. This consists of all the physicians where we talk about larger issues that affect the group as a whole. This is a chance for everyone to chime in on if they're unhappy with the way management's handling something, or if something else is there to help. So what also helps is at the end of each meeting, we do have minutes that are completed and then are shared amongst everyone.
As part of our chronic disease management, we look at a system where we query our EMR twice a year to know what patients have been seen and need something done in the next 6 months, or that they don't already have an appointment for. When we're dealing with chronic disease management, we're dealing currently with asthma, hypertension, coronary artery disease, congestive heart failure, and diabetes. What will happen here is we provide the physicians and staff members with a list of patients who do need care. This is also a very good way to track patients and make sure they don't slip through the different spots. So we have, for instance, a diabetic who may not be being followed very closely. It gives us a good opportunity to catch up with this. So it's been a great advantage to getting into chronic disease management. And we receive up-to-date reminders that when I go into a patient's file on an average day, immediately on the screen will come up a little reminder to tell me that there's something incomplete regarding one of the chronic disease problems that that patient may have. So it's very good at educating the physicians to remind them. Also, it educates patients that they need to be coming in for certain follow-ups with the various different chronic diseases.
So in our experience, there are 2 types of change. There are push and pull. There's actually only really 2 types of forces in physics. If you look at vectors, you're either pushing something or you're pulling something. A push is what you consider to be a mandated change or something that you have to do. For example, laws change, you have to become compliant with a regulatory body. That's a push. There's no real choice or discussion to be had in it. Pull is what we try to do a lot more here. Think of a force like gravity. We're trying to make something attractive to pull more people in. We found that pulling has been a cornerstone of having shareholder engagement and involving more people in the change. So we did reference a little bit of Manitoba Health's Infoway change work and how it draws connection to how we implemented these chronic diseases within our group. Our communication has been huge for getting everyone on board and stakeholder engagement, as well as when talking about training and education, simply educating the patients on what we're doing and why had a huge method to it.
When you're building change, you have to, first of all, identify clearly what your goals and outcomes are. And then one of the very important things we found out is you really need to identify the barriers to reaching those goals. And the one major issue, which became apparent to us and to members of Manitoba Health who were involved with us, was the major issue concerning the computer databases and getting computers to be able to talk to each other and having a single type of system working with different computers. And this was, we didn't really recognize how big a problem this was until we started in on it, but it became the major early hurdle that we ran into. We'll be talking about that a little later. And then you have to identify how this change will affect the rest of the system. So we had to bring in new computer systems, get the computers to start talking to each other, and there had to be a certain flexibility built into the whole system.
So just to reiterate what Dr. Rumbold said, and whenever you're building change, be sure with your goals to be clear, keep them simple, and be flexible. To do something abstract like improve patient care is more of an outcome than the goal itself. The question that keeps coming up is how. How are you going to do it? And those hows are your goals.
When we're looking at this whole concept of stakeholder engagement, the major point we want to bring into this whole discussion is the experience of a fee-for-service clinic, which is what ours is truly. We have nobody on salaries there, and so everything involves around patient care, and there's costs involved, and so it brings a different perspective into it over what some clinics may be involved with. We look at it from the physician's perspective. You have to be direct and honest with the physicians. You have to be able to answer questions for the physicians. When you're talking to physicians and trying to present a new concept, a new idea, you have to talk about what do you want me to do, and why do you want me to do it, and is it going to slow me down? And in the workplace, most of our physicians have very large volume practices, and this can really create huge headaches if you come up with some ideas that are going to slow them down on the average day. And then the other point is, why should I do this? What's in it for me? And that becomes a point, what's in it for me, what's in it for my patients, what advantages are for us to go through a lot of change and a lot of challenges. And you know, we know that this will affect patient volumes, which can translate into billings. And it's also a problem that if our practice is slowed down, it may be difficult for patients to access care because they have appointments or visits that are related to completing chronic disease management things, and so it may create some access issues for patients. Manitoba Health came to us initially with these ideas, and really it was a leap of faith to take them on, because initially the representatives of Manitoba Health came up with these just general concepts where they were talking about changing how things were done and chronic disease management without much in terms of specifics. And it's a hard thing to sell it to physicians, to start saying we need to change your work day or how you're doing things without some real clear things. Now, I think they did that on purpose, to give some general ideas and leave it open so that there could be change and keep the flexibility in it, which is one of the big points. And fortunately, the people who approached us from Manitoba Health were quite good and very approachable. They really kind of sat back, gave some ideas, and didn't push things, as Mark was talking about. And they kind of dragged us along, and it was done in a very nice way, which I think worked out very well and it was a major factor in why this succeeded.
So one key point when engaging your stakeholders that you always need to bear in mind is that you need to listen to them. Be ready to answer the questions that we've proposed, what do we want, why do we want it, but listen to the answers, not just ask the questions. There are a lot of cases where you already have your change in mind on what you want to do, and your stakeholders will bring a whole new perspective on it that you had never even realized before. So don't hesitate to reevaluate where you stand and also listen to the people you're asking.
And when you talk about early adopters, the term is used, change champions, and these are typically your most engaged stakeholders. So how do you find a group of physicians? How do you find a group of people to take on and challenge them with something where you're not giving them a lot of specifics? And this doesn't go over real well generally with physicians. We had an advantage because, as Mark mentioned earlier, we have our management committee, and that gave us 3 people who really are looking out for the good of the clinic and tend to be more involved in looking at new ideas, and because there's lots of things on various matters that come up. And this is the group that in our clinic became the lead group to set this up. So we went to the meetings, so we listened to the discussions and came up with different ideas. And so we had to, by meeting with Manitoba Health, we had to work with the leadership from Manitoba Health and be willing to have a leap of faith to accept that they were being very honest with us in terms of how they were approaching things, because we would then have to take this information and go back to our constituents, really, and sell the basic concepts of this. It also involves having, we felt, a very good clinic manager, because as you go through this, the physicians are busy seeing patients. They really don't have time to go to a lot of meetings and a lot of telephone interruptions and that. So if you have a clinic manager who's on side and is committed to at least seriously looking at this, that really helps a lot in making it work.
So just some other notes about your early adopters. They will make or break your change. Early adopters are the ones who already agree that the change is necessary and that the change is important, and they will do everything they can, tooth and nail, to help you see it come through. So the big thing with your early adopters is to support them as equals, because they will help shape and make your change come to become reality. Also, anywhere you have early adopters, you're going to have your early resistors too, and they're probably going to be the larger share. But that's okay. Just work with your early adopters, and you can always figure out what needs to happen and try to bring more on board over time. So next we're going to talk a little bit about our implementation. So starting off with our chronic diseases, we actually didn't do much of anything outside the normal medical practice. People would come in for their physicals, we'd order that, but we weren't really proactive in chasing after our patients. So we decided when Manitoba Health approached us that we wanted to go after the patients who were being non-compliant or complacent with their own health. To do this, we actually had to change our EMR, which was a big change. We started off with ClinicCare, and ClinicCare could not meet the requirements we had for what we wanted to change. So we ended up swapping over to the Freedom EMR by Genoki, and that one has seemed to have met all of our needs. The point to be made with this is sometimes a small change is needed to make a large one, or sometimes still, a large change is needed to make more large ones. So from there, we have Genoki now that allows us to query our EMRs for patients who have not been seen in the last year, who require something relating to their chronic disease care. Using that, we actually have it where it displays for the physician when the patient comes in. If an item is in red, it needs to be done. If an item is in blue, it needs to be done in the next month. If an item is black, it means it's done. You don't have to worry about a thing. And just simplifying the feedback to the physicians to let them know where they stand has made all the difference. And the design of this system isn't one that the clinic managers or the IT people can claim on their own. It's the physicians who really design what's simple, what works for them, and what works in the exam room when they're seeing a patient.
As we continue about the implementation, it's very important you seek out resources that you may have missed. And there's really a point we were making about you don't really need to reinvent what already exists. We had actually heard rumors or bits of information that in Ontario and British Columbia they're already doing somewhat similar projects. And this is really, I think, a value of the Infoway in that it would really help to be able to find out what people have done, what's worked, what hasn't worked. We're doing that now, but it would have been very helpful to us early on to sort of see where are we going with this. Like sometimes we're caught up in this and we're brought into it, and we're willing to go along with it, but you kind of don't have a real clear picture of where they're trying to get to. So again, when we go back to the other 14 physicians in our clinic and talk about this, they're looking at you like, you know, give us some specifics. We need to know what you actually want here. You know, we just don't want to have a long drawn-out discussion. The critical thing that with implementation, I always think to come back to, is the importance of the IT people. You really, especially early on in this project, the computer people were just critical to making the whole thing work. It just, I can't see that it would have worked at all, except that the IT people we already had hired here on our own really put in tremendous amounts of extra hours just trying to get everything working, and it's just, and that's totally beyond the capacity of physicians to be involved in. Even the few physicians in our clinic who considered themselves to be somewhat of, you know, fairly savvy with computers, this was just way beyond anything they could take on. So you really have to have the correct support.
And a big note to say that is don't be afraid to think outside the norm. While it's nice to look at what everyone else is doing around you and to copy, sometimes you're working on a project that's completely unique to you. And sometimes you have to come up with a solution that's even better than what everyone else has come up with. So that being said, don't be afraid to challenge a new idea. If the answer to your question why we haven't done this yet is because we've never done it before, then it's time to try it. So in any change you have, there will be hiccups. There's going to be problems, there's going to be mistakes, there's going to be errors, there's going to be goof-ups. It's going to happen. Don't sweat on them. Things are going to happen, and you're going to have to work with them and evaluate over time. The biggest thing to mention is that our first run of these chronic diseases was a bit of a disaster, I'm going to say. It took thousands of hours of physician and staff time just educating patients on what's going on, getting physicians in the habit of checking that to-do screen to make sure that they're following up with it, getting staff on board so they understand what's going on. And the first one was a huge undertaking, and the amount of effort we put into it was a huge amount. Now, several years later, the amount of effort that we put out is still significant, but not nearly to the same level as it once was. And now it's slowly being adopted into our day-to-day things. So the biggest point to take away from this slide, don't be afraid to make a mistake. We all do it. Don't be afraid to do it wrong, because if you do it wrong, and if you tried and did it wrong, it's better than having never done anything at all.
One thing I wanted to mention, just in reiterating some of the points there, was that, again, the clinic manager becomes a very important person. You've got to have that person on site. And when you're dealing with fee-for-service physicians, you've got to really look at things where you can't disrupt their day. These people work fast, they're working in high-volume practices, and a lot of them have very large patient rosters. And some of the ideas that we looked at originally would work well in small rostered clinics, but in large practices, these things are just not applicable. You just can't get the people in, you can't get access. And I think you also have to monitor for patient access, as this can influence the quality of care. You've got to make sure you can get people in for their regular appointments. And if you start tying everything up with fulfilling the needs of the chronic disease management stuff, people can't get in. And it's hard to get appointments for chronic disease management issues when patients are already trying hard to get appointments for their own perceived acute problems. So we've already got a busy practice with very little time between in terms of patient time, and now we're needing more time. And where does it come from? And you get physicians would spring it up, like, where do I find the time to do this? And so what it turns out to be, a lot of it is extra hour stuff. It's stuff that's done afterwards. Now, this is in the initial setup. Later on, once you get through the first phases, life gets a whole bunch simpler. But initially, it's a really hard sell to kind of get people to stay in tune.
It's important in any change management situation to evaluate and report. How do you know you've reached your goal? Have you reached your goal at all? Are you on track to reach your goal? What are the problems you're hitting? And one thing about reporting that we do within our group is we make it very public, not to the public at large, but to the physicians within the group and the staff. So at the end of each chronic disease run, about twice a year when we do it, we give a report to every physician saying where they stand, and on that report is every other physician and where every other physician stands. Adults are competitive people. More specifically, physicians are incredibly competitive people, and in all honesty, we leverage that to try and get the best results we can out of them. No physician wants to be the last one through the gate or to have the lowest numbers. No person wants to be the last one to do that. So by sharing our information publicly, it really pushes them to increase the quality of care they're giving their patients.
A lot of the, when we're dealing with what we're actually monitoring, you're looking for percentages. So you'd have what percentage of your patients with chronic any kind of chronic obstructive lung disease, asthma, or anything, what percentage of the required information has been provided? And that's kind of what you're looking at in terms of competitiveness, to try and get it on site. So if you have a patient with diabetes, you want to make sure that they've completed all the required things within the time frames that have been allotted for it.
The other thing we did with this change that really kept us on track is, especially early in the change and then as time has gone on, was frequent reporting. The frequency that the doctors received these reports was actually every couple of months to begin with, and then as time has gone on and we've grown more accustomed to this, we've started to report less. The main reason why reporting is important is because it keeps the change fresh in people's minds, as well as gives them a feeling of accomplishment as things develop. So if we were to, say, start a project and never tell anyone about the outcomes of the project, you'd be surprised how quickly that project falls on the back burner and never goes anywhere. Even if you're collecting the right data, collecting the right analytics, if it's never reported back to the people who are actually putting forward the effort, it doesn't actually change anything.
Yeah, when we look at a review of the whole thing, have we really fully reached our goals? And could we be doing things still better? And do the stakeholders have any other ideas? And this is one thing we brought up, just that if there were new ideas that members of our group noted, or something they thought would be helpful in monitoring a person, say, with congestive heart failure, then we could look at adding this to the list. Now, we would have had to take this through Manitoba Health if we did any real changes. But initially in the initial setup, we're just trying to keep our heads above water and kind of get things done as it was proposed by through Manitoba Health, you know. And just when you review the whole thing, initially it was more of an act of faith more than any tangible financial benefit or benefit directly to our patients when we went to this whole project. And the big thing we had initially was to upgrade the CMR, and this led to, there was a tremendous amount of data that had to be inputted that physicians had to do on the weekends and after hours. And this, again, can be a hard sell when you're looking at what do you have to worry about? You have to worry about presenting it in a way that will get people interested in taking it.
So some key elements that led to our success was the inclusion of all affected parties, keeping the physicians involved, keeping the staff involved, keeping things simple was a key element, just making sure that it's something that could be worked with in day-to-day life, as well as being flexible, listening to feedback, and constantly giving feedback. Just some future points on change. There's a lot more we plan to do with this project in the future. We plan to make it simpler still. We plan to get more patient involvement. We plan to look at how other people are doing things and seeing if we can incorporate that into our own practices. And then finally, the biggest errors that we had were ever having big or complex goals, because they always fell out of sight. We never did them. We focused on, or we spent some time focusing on our resistors, not our early adopters, and then always just make sure clear communication. And I believe that comes to the end of it. So as of today, we are roughly 80% compliant on our CDMs across the board. So amongst the 17 family physicians, 80% of their patients are fully taken care of by key indicators. And there are, of the remaining 20%, there's a mixture of non-compliant patients, people who refuse to come in, patients who, for the best care of their health, we shouldn't be doing what the standard normal is. So that's how we've been handling our chronic disease. So back to you, Karen.
Thank you very much, Mark and Dr. Rumbold. That was a great story, and I'm sure we'll have questions at the end of the presentation about how you did some of the things and some questions, but gave us great insight. I now am going to pass over the presentation to Mirella Chiodo from the Department of Family Medicine, University of Alberta, to tell her about her journey when it comes to implementing change. Here you go, Mirella.
Karen. So yeah, we're going to look at the team-based model we created at the University of Alberta at the Department of Family Medicine to help us manage change in our 4 academic teaching practices. And just a little bit about myself. I've held this Quality and Informatics portfolio for about 9 years now. And in addition, up until a year ago, I spent about 10 years doing contract work for the Physician Office System Program of Alberta, assisting clinics in EMR use and particularly teaching them how to use the EMR to complement their new and existing workflows. And finally, with the support of the Department of Family Medicine, I offer in-kind support to Alberta AIM as Alberta AIM faculty, which is a provincial program where we lead clinics through an 8-month collaborative in-process clinic redesign, so to speak, teaching them strategies for access improvement, measurement for improvement in clinical office efficiency. Now, I tell you this because all of these roles combined have allowed me to work with well over 100 clinics across Alberta. And it's given me the valuable opportunity to see how folks manage or sometimes don't manage change in a variety of settings. So it's been just as much an educational process for me as the clinics I served. And just a little bit about the very complex organization that I work in. The Department of Family Medicine is responsible for training physicians in the discipline of family medicine. We roughly have about 180 residents we're teaching in any one given year. And 75 of those are being taught directly in our 4 academic teaching clinics. Now, these clinics are just regular primary care clinics offering cradle-to-grave care. We have roughly 20,000 active patients, 60,000 visits a year. And in addition to the residents, we have about 27 physicians. Some are professors and some are clinical preceptors, and about 50 multidisciplinary staff members. Now, to further complicate matters, we don't own our own clinics. They're basically sort of tripartite run. What that means is the health authority, and in our case, Alberta Health Services and Covenant Health, own the facility and they manage the unionized staff. Then the physicians are part of the university and they own their practice, and the custodians of their medical record. The university also manages some of the staff in the clinics. We have something in Alberta called primary care networks who get funded on a per capita basis, and those funds are used to put staffing resources in the clinic to promote team-based care. Things such as dietitians, chronic disease management nurses, psychologists, kinesiologists, screening clerks, that sort of thing. So you can see the governance structure is really quite complex and very difficult to make change happen in an environment where you have so many masters. But, you know, where there's a will, there's a way. So today, you'll see the model or the team that we came up with to help support change in this complex setting. And then we're just going to look at a few of the examples of change initiatives that we've undertaken. So when I moved to this role, I decided I needed to get a lay of the land. So I started spending time in the clinics and getting to know the people and their processes. And you can see some of my primary observations on the slides above. I quickly realized that there were so many pockets of brilliance at all the sites, but there was no cross-pollination of ideas, no sharing of best practice. They were all basically working in silos. And when I spoke to physicians and staff, they all felt their clinics were different or special. But as a third party looking in, it really became obvious that they really all did the same thing. They had the same mandates. They taught residents, they saw patients, and they all did a great job at it. They all had similar roles in the clinic, same philosophy. So I decided as part of my change management to focus on the similarities they had to try to get them to move forward. And this is just a quote from Dr. Mark Murray from Sacramento, California. He's one of our mentors in the AIM work that I do. And basically, if we keep doing what we're doing, we'll just keep getting what we've got. And these clinics operated this way for like 30 years. And so after sort of doing my initial review, this was the mandate that I was given. All of our residents were exposed to very different experiences depending on which clinic they were placed in. We needed to change that. And so as part of it, we needed to implement EMRs in the clinics, have a quality improvement framework that all the clinics could follow, transform these clinics to a patient's medical home environment, and develop a measurement and evaluation framework. And I can tell you, I mean, those are pretty lofty goals, and they certainly didn't happen overnight. And to be honest with you, we're still working on those last two bullets right now. And so our biggest challenge was to get folks to get past that sense of autonomy. Each physician and each team had their own rules, their own ways to practice. We had to get them to see that they were all part of a system, and the way they practiced affected the rest of the system. And then we also had to get them to see that they were part of the bigger educational system of the Department of Family Medicine. And so how do we make change happen? Well, I mean, in nature, it occurs organically, and it's quite lovely. This poor caterpillar has no choice but to change. Even if you were afraid of heights, you'd still have to turn into a butterfly. With people, not so much. People need to make that conscious decision to change. And as all of you know, no one really loves to change. And being the person to deliver change certainly isn't the most attractive role. So I started researching improvement in methodologies, change management methodologies. And in the process, I became ProSci certified, but to be honest, I really didn't stick to one framework. I pulled from many and continue to pull from many. And so here, the two that you see before you are the Canada Health Infoway Change Management Framework and the ADCAR model. And as you can see, they complement each other quite nicely, and this is what I found pretty much in all the reading that I did. The ADCAR model are traits that the individual requires in order to change to occur at the person level. And in the Infoway model, we see the actions that are required for those changes to occur. The other thing I noticed really quickly is that it wasn't that clinicians were simply resistant to change, although, I mean, I must admit I did encounter a few that were. But what occurred to me was that they simply didn't have the time. They all had great intentions. They wanted to do better. They wanted their clinics to operate more efficiently, but they simply did not have the time to organize it. And particularly in our academic centers where physicians had so many competing commitments. They were academics, they taught, they had various streams of clinical work. Many of them did research and were on like hundreds of committees. So I figured out pretty quick that I needed help. I couldn't do this alone. And so we needed a champion at each of the clinics that was going to fill the gap that the physicians were unable to do. So we got together at the department level and started to come up with what sort of a role did we need. And as you can see here, there's quite a variety of experiences, and it was absolutely impossible to find 4 people with all this variable knowledge. basically, once we knew what we needed, the important thing was for us to find an IT savvy person, not necessarily an expert, but somebody who was willing and flexible and willing to learn. And we did have the luxury of time on our hands, and so we could develop our own role. And so we called this role the quality coordinator. Now, the role took about 12 to 18 months to develop, and to be honest with you, it's still a developing role, and it develops continuously. We meet twice a month. The training is done in-house by myself, or I bring in external experts whenever required. But to be honest with you, they love their role, and there's been virtually no turnover in the past 6 years because it's interesting and it always keeps them learning. And on the screen, you're going to see their basic duties, but these are really basic because the role really is a catch-all, and in fact, their duties probably cover about 2 pages on their job fact sheet. But all the team members, even though they're responsible for their own clinic, have access to all 4 clinic systems. We've introduced them at all the clinics. They know all the staff. They know all the processes. I have access to all 4 sites. So basically, when one of them is away on vacation or sick, there's no interruption in our service. We completely cross-cover. And so the secrets to our success so far, definitely I must say, has been this quality coordinator role. And then, of course, we've also worked with our center directors who in the past had more of an oversight to the educational side. How are the residents being taught? But we've sort of made it so that they have more of a clinic management role as well. And then, of course, all our clinics went through an AIM collaborative, and this gave them the basic understanding of quality improvement, measurement for improvement, and it gave them a validated framework to use in their improvement work. So this is the AIM framework for improvement that you see in front of you. And you can see, again, it aligns quite nicely with the Canada Health Infoway framework. It's basically team, aim, map, measure, change, sustain, and spread. And then, of course, we use the model for improvement as our foundation for testing changes in a very limited setting, while ensuring that we measure to prove the changes and improvement before we spread it to the other members on the team or other clinics. And so my team is pretty much responsible for these elements that you see here of the Canada Health Infoway framework. As for governance and leadership, although we're not directly responsible, I do meet with upper management regularly at all levels to ensure that the appropriate messages are being delivered and that they're being delivered by the appropriate messenger. As an example, if we're speaking to the Alberta Health Services staff, it's very important that we get an Alberta Health Services manager to send those messages. And communication is probably where we had the biggest gap. In the past, there had always been a real disconnect in getting messages from the department level to the clinic grassroots level. And the university was seen sort of as an ivory tower. So we actually started a communications working group, and we ended up actually formalizing a communication strategy. And trust me, you can never be accused of communicating too much. And then prior to having gone through AIM, the clinics were famous for jumping to solutions. They would make ad hoc changes without considering consequences, and certainly without knowing if the change was going to be an improvement. And what my team does now is we ensure that the teams have a good understanding of the current state. We involve the people that are doing the work to actually change the work, and then we map, measure, and change. We try it with one team, and then, of course, we scale it up. We attach measures to show our success, which really helps in the spread of innovation, and it gets at that desire for the others to want to move forward as well once they see sort of the numbers behind, oh, you know, this really does make things better. And then, of course, training and education. The clinics are really busy, and as you know, rarely do you get all the folks in one room at one time to get training done, for instance. And so things like one-off vendor training just didn't work well for our sites. And so we always have used the train-the-trainer approach. Essentially, the quality coordinator trained by myself or by external resources, and then they go back to their clinics and use various training methodologies there. So they might do big groups, they do smaller lunch and learns, they offer one-on-one, and they offer on-the-ground as you're working sort of help. for big changes such as, let's say, a larger EMR change or upgrade, we ensure that all the clinics are being upgraded on different days, and then we send my whole team to one clinic. So that's 5 of us on the ground that are there to help people as they're doing their work get through their day. And then, of course, monitoring and evaluation. Measurement definitely guides all of our quality improvement work. We've got it embedded in the job descriptions. It's not an add-on, it's an expectation, and staff is definitely given time to do their measurement work. We're transparent about our measures. They're posted in the hallways, emailed to staff, physicians, residents, and measures are reviewed monthly at physician meetings, team meetings, and at the department level. And these are just some examples of some of the changes we've rolled out. Of course, the one probably most of you are familiar with, the big EMR implementation. Of course, we've implemented quality and safety in primary care programs, Alberta screening and prevention initiatives, and care plan outreach. And this is something where we, similar to what the group before me said, where we send out screening and chronic disease management criteria to patients along with the requisitions for the year. And then the one I'm going to dive a little bit deeper in is something we've called the Metrics Project. It's a project that we're working on right now. And the scope of this project essentially is twofold. One, we're trying to come up with meaningful performance measures, process and outcome, that can be displayed in the dashboard format in real time on the physicians and staff EMRs. And then the second part is evaluations of team structure, processes, that particularly in the area of chronic disease management, and it's using standardized surveys that are out there. And so here you just see a table with some of the activities that we've completed or about to complete, and how they relate to the framework. So for governance and leadership, our chair and the managers have been communicating this vision probably at least 6 to 8 months before we even started. Communicating by email, by newsletter, in person, any way that you can imagine. And then for stakeholder engagement, our working group actually consists of 2 physicians from each of the clinic as well as the managers. We wanted this very much to be a bottom-up approach as opposed to the department deciding what the metrics were going to be and then just telling everybody. And then communication, like I said, I've mentioned how many different methods we communicate. Workflow analysis and integration, we involve the EMR vendor, we map out the processes, and we continue to create a rollout plan. And the training and education, by having these 2 physicians on our working group, what we've done is we've created a champion at the site besides the quality coordinator, and the managers come to these working group meetings too. So they have all the information they need so that when questions come forward, they're able to answer them all. And then, of course, in our monitoring and evaluation, we're transparent with our measures. We've committed to reviewing the measures on a 6-month basis because we don't want sort of any unintended consequences of these measures. We want to make sure that they still fit with the mission and the vision of the clinic and the department, because as things change, guidelines change, measures change. And that's about it. And now I'm going to pass over to Karen again.
Thank you, Mirella. That was a great presentation. Thank you so much. You covered a lot of ground, and you seem like your team is very busy. Very much appreciated that. I'm now going to move forward and see if we have any questions from our participants. I do have one that's already sitting in the queue, and I imagine this is for Dr. Brian Rumbold or for Mark. What CDM measures are you using? Hello, Mark and Dr. Rumbold.
Sorry, we forgot the mute button here.
That's okay.
For instance, with the diabetes one, well, you have to have a hemoglobin A1C done every 6 months on the patient. You have to be checking their lipid profile at least once a year. They have to have a blood pressure reading. BMI has to be done. They have to have a nephropathy screening, so albumin creatinine ratios. They have to have a foot exam done, and they need to see an optometrist to have for diabetic retinopathy. So that will be and once you've completed all those components, the 8 components of that, then that will be considered having completed that one for that year or that period of time. And hypertension is blood sugars, lipid profile, blood pressure readings, obviously, and a body mass index. So each one, they have specific criteria, and these would all be on the screen. If you've done none of these things on a patient, the little red box or with the red writing in it will have all of those things on there. And as you complete any of them, then basically they just disappear and go to a black sort of on the screen.
So we do actually monitor 5 chronic diseases. We go after congestive heart failure, coronary artery disease, asthma, diabetes, and hypertension. And in coming years, we're planning to add a couple more.
Great, thank you very much. Mark, while I have you, I have a quick question for you. You have a large number of medical office assistants. What role do they play in supporting or leading change at Assiniboine Medical Clinic?
A good chunk of that comes down to our hierarchical structure within the clinic. The way we view ourselves in the clinic is it's not who you're responsible for, it's who you're supporting. So at the top of our list, we have our patients. Below those, our physicians support our patients. Below that, our receptionists support our physicians. And below that, the management and other staff support the receptionist. So essentially what happens if a physician wants to change, it follows down the line for everyone else to support everyone else.
Well, that's a great concept. I'm sure that's very supportive and very collaborative and leads to great stakeholder engagement. Thank you. So I guess this is for Dr. Rumbold. You mentioned the fact that, you've made some errors like everyone does when they start change initiatives by not communicating or being clear enough or not being in terms of what the goals are. Have you ever had initiatives that never got off the ground due to lack of physician interest?
Well, there was one project we had in the last couple of years. Initially, Manitoba Health wanted to develop access clinics around the city, and in the case we were involved in, they were developing one for the west end of the city where our clinic is located, and they asked us to a meeting where they just had someone just to get ideas because they felt that they wanted to really make this clinic work really well. And basically, we got almost no useful information, and when you have a bunch of physicians sitting there, as I mentioned during the presentation, when you just come up with just general concepts and they really didn't have any specifics of what they wanted, it just kind of, the physicians lost interest very quickly. And it's just very difficult to reignite any kind of interest in anything when you've had a shot at it. And it was just the general ideas. I think when they came with the information and the proposals, they really hadn't been fleshed out enough to make anything useful. It was just, well, we just like to get your ideas and we'd like to see where this goes. And we're not happy with the other clinics and we want to do it better this time. And in the end, they ended up setting up the clinic that basically was the same as the other ones they'd already set up. So in the end, our people had no involvement. So.
Okay, well, thank you. I've got some more questions for you. It says, for all presenters, what are some of the practical things you did to address the physician concerns about the impact of change adoption on their time? So I'm going to give you guys a moment to break in Assiniboine and talk to Mirella. You mentioned in your presentation the importance that physicians are very busy. How did you manage that? What were some of the tools that you did to help them?
Well, the one benefit that we did have, and the way we're probably different from many clinics, is our physicians are actually in a salaried environment. So I must say, and having worked in community clinics, it's quite a difference in setting. We don't quite have that, as busy as they are, it's not to say that they're not busy, but we can actually book off time to get them together, and you know what I mean? It's not so much that they have to, taking a little bit of time from the schedule isn't that drastic as it is in a community clinic in a fee-for-service environment. So that's one of the benefits that we did have. Communication was key. Having gone through AIM, we try to take as much work away from the physician as we can, so have other staff try to do as much work from them so that they're left with sort of the bare minimum that only can be done by them.
Okay, thank you. Dr. Rumbold, do you have anything to say on that topic?
Well, that's a really difficult issue, and it's one you come up with. I think one thing, in ours, after the initial leap of faith sort of part to follow the management committee ideas, it became obvious that there was going to have to be new computer systems. So one of the ideas is computer systems cost a lot of money, and if you're looking at potentially at the provincial government helping out with some of the costs, if not all of the costs of that, at least there's some tangible benefit for the physicians to put up with, and it really was hours and hours and hours of work to input a lot of the data. At least to give you something. And I think looking forward in other projects, I think having some incentives built into it, whether they're financial incentives, there have to be things for the patients. The patients have to gain from this, but you've got to make sure the physicians are not being, worked right to the bone with these things. So some sort of incentive, whether it's a financial gain or whether it's helping it with computers or some fashion making it work, I think becomes really important to attract fee-for-service physicians, because they do. They come, some people feel fee-for-service physicians tend to be a little harder on things. If you're in a salaried position, well, we've got time for meetings. Our guys will fight you over meetings, and then they do come to them. When we're doing our training, for instance, to switch over to the new computer systems, because we're using Genoki now, we would set up sessions starting at, 6:30 or 7 in the morning and just run for an hour, and we had a whole room we set up with computers so they could be taught. We had trainers brought in, and, there's different ways you could do this because you don't want to interfere with their workday. You start interfering with their 8 o'clock appointments, you've got a problem on your hands. Whereas if you sort of say, would you come in early? Yeah, they'll be willing to do that every now and then, try and make it work.
And I think a point to make when trying to manage change within a fee-for-service environment is it's important to communicate, it's important to have meetings, but make sure those meetings are valuable. Make sure at the end of the day, if the physician is giving up time with patients, he's getting something for his time. And not necessarily financial. It could be knowledge that he was lacking. It could be a say in how things are done that you've actually listened to him on. So as long as the meeting is valuable.
Thank you. Those are all good points. I can see where, it reminds me back of your statement. You have to be flexible. You have to know who your stakeholders are, know what their barriers are, and how to work around them. So it's like you've all had a chance to do that in your change initiatives. Another question from a participant. We can hear from both the different clinic settings. Has your clinic chosen a classification nomenclature? For example, are you using ICD-9 or 10 or SNOMED CT? Do you have any of those? What are you using in Assiniboine at this point?
So ICD-9 is part of our billing within Manitoba. For our chronic disease care, we actually do not use it as an indicator of whatnot. Within our EMR, what there is something called stickies, which every time a physician sees a patient, say, with hypertension or diagnoses a new patient with, say, diabetes, they add this sticker to the chart. It's a digital sticker. That automatically updates the problems list, that updates the prevention items that physician needs to take care of, that also updates anything else really relating to that condition that the physician would need to track. This sticker also does double duty in the sense that from the administrative standpoint, now my problem list is up to date so I can search the database easily, and it has all those prevention items. Also, when the physician clicks on the sticker, it gives them all the historical lab data relating to that condition.
So would this sticker then be an ICD-9 code, and they just keep putting it in places they need to use them? Is that what an ICD-9 sticker is?
It has the ICD-9 code attached to it, but to keep things simple for the physician so they're not memorizing codes, it's in plain English. So Dr. Rumbold would pick the diabetes sticker, not necessarily knowing the ICD-9 code, but it does have the code attached to it.
Yeah,
awesome. That's a great way to use it, to work around it. Dr. Rumbold?
No, it's really simple. It's actually, for diabetes, it's a blue square with a D, a big white D in the middle, and all I have to do is go Alt and then tick on that, and it shows up as a sticking thing. So it makes my day kind of easy. It doesn't add a lot of time. And that, again, if you have a bunch of steps with each patient every day you have to go through, that is a barrier to people agreeing to join something. Whereas if you have something as simple as that, and that's a one-time thing that brings that patient in. So we'll have patients that have huge numbers of stickies. They may have 6 or 8 different ones for different illnesses, and that will allow us to keep track of everything.
Awesome, great. And Mirella, in your clinics, what do they use?
Similar process. We use ICD-9 as well. We use the Access EMR, and the capability is there for SNOMED. But for chronic disease management and health screening, it's a very, very similar process where, depending on how the patient is tagged, and their age and sex, certain reminders will come up. Either you can go look for them on one page if you don't want sort of the reminders popping up in your face all the time, or you can set it up as something called chronic disease management triggers. And they'll come up as required as well. So it's pretty slick.
Okay, well, another question for you, Mirella. Can you elaborate on why EMR, IMIT knowledge and quality improvement is a synergistic mix in your QC team? How does this relate to measurement as well?
Like I said, it didn't take us very long at all to figure that out. I mean, basically every clinic process It became evident once we started implementing the EMRs, because that was kind of the first step we made in standardizing the clinic. Every clinic process touched the EMR, and these girls learned the EMR very, very well, and they all had a bit of a clinical background enough to know how to make it work better. And so quality improvement just fell into it. And of course, with measurement, these girls, they know how to pull out their data. They know the importance of putting the data in a way that will make it easier to pull it out. And so the three just work. It is a synergy. It really is.
Okay. Our final question I'm going to have for you, Mirella. How do you continue to build the knowledge base of your quality coordinators? We've just completed our analysis on our change management survey that we conducted in January and early February. And one of the questions that came to light is people don't have change folks available, so they have to sort of create them. And then when you create them, then how do you continue to educate them as they go forward? What process do you put in place to keep your quality coordinators on the change management track?
First of all, we make it part of their performance appraisal. So basically every year they have the question to say, what have you done? This is sort of on their own learning. What have you done? And then they have another question that says, what are your goals for the future? And we make it part of their performance, and we work on a learning lesson plan for the year together. But then we offer lots to them. Like they go through quite a few courses here at the university, things like conflict management and communication, emotional intelligence courses. We send them to privacy training courses. They do the iHigh Open School modules. So there's lots that we offer. We send them to the EMR conference every year, and I've even sent them to Kelowna to spend a day like with the vendor, right? So we just, education is huge, and it's continuous for us. So it sounds
like it's built into the development of your role and continues to be. Well, thank you very much, both Dr. Rumbold, Mark, and Mirella, for great presentations and great insight. We had some very good questions. Just to remind everyone that's listening on the call, we do have a framework, as we mentioned, and we do have a toolkit there that has all kinds of information. We have our new website has been released, so it's all been rearranged, so please go in and have a look. There's a repository there. If you have any more questions in regards to this topic, we do have a LinkedIn site that's called the Pan-Canadian Change Management Network. It's a member only, but if you go in and sign up, I will grant you access and we can have some more discussion there. I'll be posting some questions for our presenters in the next few days, so please do join us there. And just a reminder that following the webinar, an email link will be sent to you with an evaluation survey for our registered participants. That just allows us to get a sense of, are we giving you good quality information, and are we meeting your needs when you come to spending a time with us for our webinars. We very much appreciate you taking our time today and our presenters, and we thank you very much, and hopefully we'll have you join us at another webinar in the future. Thank you.